right. Good morning, and thanks to Dr. Pratt and Dr. Williams for the opportunity to present. And I think the nice part about this is everything that I'm going to talk about in the next 10 minutes or so has already been touched on in one way or the other, and that leaves me with the task of delivering pretty much a data-free talk, which is nice. And also, Dr. Rogers, if she's still here in the audience somewhere, thanks for bringing up my one death during my initial bariatric experience. I'm having PTSD. And just as an added note for the younger folks in the audience that are thinking about doing this type of surgery, literally this was like, I think, my 10th bariatric operation, and needless to say, it was a defining moment, certainly for that family and for that poor patient, but for me as well as a practitioner that does the kinds of things that we do, after having a good cry and some counseling sessions with my boss, I pushed on, and I'm really glad that I did that. So thanks for that reminder. Anyway, these are my faculty disclosures. I do get some honoraria from Intuitive Surgical, and I'm a current shareholder. Learning objectives. Again, we've talked about a lot of this already, but I will touch base just briefly on the demographics and how that serves as an imperative to treat. The evolution of best practices, we've already had a couple of mentions of that, but it is, I think, important to just kind of acknowledge how best practices do evolve over time and are the conglomeration of consensus that's built at a national and international level. I want to talk about some of the program developments because, again, we've already, and Janie already mentioned nicely that, programmatic elements really do depend upon what your vantage point is, where you are, what type of surgeon you are, and what type of institution that you're functioning in. And with that being said, I want to immediately acknowledge that there is no one recipe or cookbook for how to do this. What I'm going to show you is the way we do it in Columbus at Nationwide. It has some similarities and some differences from other people on this panel, as well as other people that have experienced doing this around the country. There is some framework around this, though, that I think is worth mentioning, and we have all talked about or heard about a little bit about MBSAQIP, and that does serve as some framework for individual institutions that are thinking about developing this type of treatment paradigm, and then touch base just at the end on a little bit more on some of the access and challenges that are ongoing and quite significant. I'm not going to spend a lot of time. We already know that obesity in childhood is quite prevalent and quite concerning, especially in and amongst the adolescent population, and we go up to class 2 obesity or higher, or BMI of 35 per kilogram per meter square or higher, or however you want to define it. That's a whole separate talk. Overall, for the entirety of the population, we're talking about 4.5 million individuals fall into the category of severe obesity, which is, obviously at a surgical meeting like this, an anthropomorphic benchmark that really speaks to this as a invasive treatment paradigm. If you look at some of the NHANE data, I don't know if anybody remembers this, but there was some initial signaling several years ago that suggested that actually maybe we were making some progress in the treatment and prevention, non-surgical treatment and prevention, with some evidence from NHANE suggesting that even in lower age groups that there was actually some decline in prevalence and some stabilization in older children. Follow-up analysis, again, from the same data source really did not support that. And indeed, the news is bad and appears to be getting worse all the time, coupled with the fact that, as we know, severe obesity in children is a high predictor for severe obesity in adults. And when you couple that with all of the comorbid conditions that we've heard about already this morning, certainly this rounds out the picture for the imperative to treat. In terms of building consensus, and I put two-pronged approach there because I think as surgeons we tend to talk at surgical meetings and talk to other surgeons, and we get into this echo chamber. And I think, again, for the construct of consensus building and best practice development, it is important to bring all stakeholders to the table to talk about this. So for me, two-pronged approach meant surgical and non-surgical. In 2004, our colleague Tom Inge led a group to put together, I think, really the first organized consensus of what bariatric surgery in the adolescent population would be. Prior to this, there really were no guidelines or recommendations, and this admittedly wasn't based on a whole lot of data. And the criteria themselves actually were relatively conservative in terms of when you would engage using anthropomorphic measures, BMI 40 with severe comorbidities or BMI 50 with less severe comorbid conditions. And as time has gone on, Dr. Pratt, I think really was one of the first to readdress this and try to bring down the anthropomorphic qualifications for eligibility based on now some accrual of data, which I think was a great thing. Still not quite identical to the current NIH consensus guidelines that have been around since the 90s for the adults. This started, I think, triggered a conversation that really spun out into more of the societal consensus, both through Children's Hospital Association and initially by ASMBS back in 2012 as the first endorsement and publication of guidelines, which, as we know, have since been updated most recently in 2018 and have really served an important platform for how other programmatic elements and policy development has been driven from there. Here we can see that the anthropomorphic qualifications for eligibility are identical to what the adult population has been for that many years longer, and so that's been a good thing. Back to this whole, where do you do it, and a pediatric only program like mine versus adult programs that have pediatric indications. Again, that's a big question, and we can spend a lot of time talking about that, but somebody asked a little bit about who's doing this. And so, again, recognizing that MBSAQIP is not capturing all data that is associated with pediatrics, here's what we know. Currently, there are only six, pediatric-only MBSAQIP accredited centers, so freestanding children's hospitals that only treat children in the U.S. However, there are 106 adult centers that have pediatric indications. So there's a story here. Right now, the bulk of the pediatric operations are probably happening at the standalone centers, these six, in terms of average annual cases. The adult centers, however, this is really where we need to be paying attention, because if one were to predict, and these numbers are going to rise, that adult centers really do have a very, very important place here. And even though somebody like me and Cordelia are interested in doing this from a pediatric standpoint, there are a lot of our colleagues in the country that have no interest in doing bariatric surgery. That's not why they went into pediatric, general and thoracic surgery, and that's fine. So really, we do need to spend time talking to adult bariatric providers, adult bariatric surgeons, to increase that number of 106 and bring it up as the future goes on. Some of the things I'm going to just touch on, I think in the remainder of this talk are, again, PED-specific considerations. The operations are the same. It's everything else around it that really needs to be paid attention to. Again, whether or not you're in a pediatric institution or an adult institution with a pediatric component, or just with a design to provide this type of care for the pediatric population. As I've already mentioned, pediatric stakeholders are important. It's been mentioned by a number of people here on the panel that people who provide pediatric or adolescent care really need to be at the table to help these patients. And there's really a greater emphasis, and I think you've already gotten a taste of that. There's a greater emphasis on integrated healthcare management within the surgical program, and that's a little bit different than a typical adult program. That translates into more time. The average patient in a pediatric program usually spends, optimistically, 6 to 8 months in a program. Sometimes it's much more than that. Sometimes it can be 10 months. It can be a year. It can be more than a year. For all of the reasons that have already been mentioned here, and we can touch on it. This is busy. This is just our flow diagram of how patients move through our program. But I think it touches on a couple of important things. This clearly is a picture of a multidisciplinary care. Patients come into our system. They're evaluated. Candidacy is essentially determined on a number of different things. And then they come to the team. They see me, they see the medical providers, they see the dietitian, the behavioral health people, the exercise physiology people. And during that time, here's really, I think, one of the major differences. A lot of the comorbid conditions that go along with obesity in childhood, they are unbeknownst to this patient, and they do not exist in the patient's medical record. So this is where there's a big split in classic adult care versus pediatric care. It's incumbent upon pediatric bariatric providers to figure out what's going on with this patient. That's what takes time. And so it's not uncommon for patients to then be farmed out to various subspecialty providers for consultative services and management of various disease states. And again, this eats up a lot of time, and ultimately, we converge back to sort of the other constructs around bariatric surgery, including the documentation and all of the things that we need to go through to get patients approved and ready to go. The other aspect of this, and Numa, gave a great talk about this that included aspects of social determinants of health. This is another very big aspect of pediatric care that probably is different than the typical adult program, meaning that we spend a lot of time looking at issues around social determinants of health, food security, financial security, housing security, transportation. These are all the things that really are regularly assessed in our sphere. So in terms of what are the actual components, the Teen Labs group, which we've talked about a little bit many years ago, we queried our own centers that were enrolling patients into our NIH study, and just to come up with some commonalities and components. And I'm not going to spend a whole lot of time, but it's been touched on. Who's the bariatric surgeon? Is it somebody like me? Is it somebody like Janie? Is it a combination of both? The answer is yes, yes, and yes. I don't want to spend a whole lot of time talking about that. The medical director, that's key. It's been mentioned, you need somebody in this practice needs to be familiar with pediatric or adolescent medicine. It doesn't necessarily need to be a pediatrician. It could be, a family practice person, obesity medicine, but somebody who has some focus or interest or passion for caring for kids, because kids are different than adults. Same thing with behavioral health. We need someone with some type of adolescent experience to be able to connect with these patients in the most efficient way. Same thing goes on with our dietitian and the other components that are more generic in a way, activity specialist, a physical therapist, some type of issue like that, and then of course program coordinators. We've talked a little bit about age. Again, lower age limit. There's not a lot of data that really supports what a lower age limit is. This has been an issue that we've talked about on the standards committee at at ACS, in and around tweaking MBSAQIP. Happy to answer questions about that. Upper age limit. What is the upper age limit for a patient in a pediatric program? Again, it's complicated. Right now we use age 18 as a hard stop for adolescent versus adult. That's a legal definition. It's arbitrary. There's a lot of data to support the concept that neurodevelopmental evolution goes on until late 20s. So, it really just depends and needs to probably be assessed on an individual basis. Support groups, it's probably not a great idea to plug a 13-year-old into an adult support group. Social differences and social paradigms around what defines support for an adult undergoing bariatric surgery versus a pediatric patient undergoing bariatric surgery are wholly different. Finally, to wrap up, obviously we've mentioned some of the accreditation framework, MBSAQIP. This started as early as 2014 and has been revised a number of times. There is a new revision coming out later this year, probably in the next couple of months. This has all helped to circle back to other endorsements. We've already heard about the policy statement from AAP and the upcoming and much anticipated clinical practice guideline for childhood obesity, soon to be out later this year from the American Academy of Pediatrics. I'm not going to read through all of this slide. Again, we know that MBSAQIP does not capture all pediatric activity, but for individuals that are either in adult programs thinking about pediatrics or in pediatric institutions thinking about bariatric surgery, it is a good guideline to define what really are the factors and parameters that need to be in place to offer this kind of care. And specifically, just as a reminder, people that know something about caring for children is vitally important. It's much, much more than just the operation, which, we should assume. You've already seen this slide from Dr. Griggs. Again, just from an access standpoint. Oops, I'm not going forward anymore. Okay. Oh. No, thank you. Sudden change. Anyway, what's the point here? The point is that we're only seeing about 1,700 cases a year. That's compared to the adult world, which is approaching about 300,000 cases a year. So access is an issue. We know from prior studies from our group that only or less than half of patients that have bariatric surgery in the pediatric age group that have it as a covered benefit actually get initial approval. And the number one reason is age less than 18 for denial. This can be overcome in many instances, but requires a appeal process. That can be as many as 5 appeals in this study. Think about that. Try telling a patient that they need to appeal their denial the 5th time. Probably you're not going to get a good response. So in conclusion, and sorry to run over a little bit, current evidence supports bariatric surgery. We've heard that through all of this. Programmatic development is really founded on patient-centered, multidisciplinary, pediatric-specific care. Pediatric-based care is more centralized. As I've mentioned, there are some things that we need to do that are probably not as common in the adult world or the adult model. Requirement for ped-specific providers and stakeholders. ASMBS and the college have really helped to establish some very important accreditation framework and standards. And again, we should all look to these frameworks as a template for program development. AAP, the bullhorn of pediatric care in the United States and beyond for that matter, has wholly endorsed bariatric surgery for kids, and there's more on that to come later this year. Access to care remains a significant challenge, and new policy guidelines really should hopefully help to increase referral rates and better access for care. And with that, I will stop and thank you so much.